All right, welcome back. We're going to move on with Module 3 of our Triage to Alternate Destination program today. So this is where we really dig into some of the specific mental health conditions that you guys are going to see in the field.
At least the four most common.
Exactly. So with that said, we're going to talk about some learning objectives here. So we're going to talk about schizophrenia. We're going to discuss its signs and symptoms and some of the common medications that are used to treat it. We're going to talk about mood and affective disorders. Again, signs and symptoms, common medications and treatment. Anxiety disorders with the same breakdown, personality disorders, and then we're going to go through a case presentation where we really talk about, hey, this is somebody with one of these mental illnesses, and is this appropriate for us to head over to a Triage to Alternate Destination site? So the first mental health condition that we're going to talk about today is a real big one, and it's one that you guys are all, I'm sure, familiar with. You encounter a lot of these patients in your work, and that's our schizophrenic patients. So schizophrenia is defined as a chronic and severe mental disorder that affects how a person thinks, how they feel, and how they behave. And this condition often involves episodes of psychosis, where there's a distortion in the way that people perceive their surroundings. It involves hallucinations, it involves delusions. So a lot of times people come in with religious delusions, like God is speaking to me, or that they're seeing things in the room, or a common one is somebody's out there, the mafia is trying to kill me, those types of delusional things. And then it also often will present with what we call disorganized thinking. So you and I are just having a conversation. Somebody who's disorganized has a difficult time putting words together and just being able to speak and to go about their day.
And I think it's really important to point out that especially in the Sacramento area, we got a pretty big methamphetamine problem, and they are psychotic as well. But this is different. I think, and you're going to probably get into this, but I think that this is the high-functioning high school student that goes away to college, grades start to fall, and they're beginning to hear voices, and they're beginning to hallucinate, but they don't quite know what's going on.
Right.
And they end up coming in, and it usually does happen that way. Kind of younger individuals,
late teens, early 20s.
Late teens, early 20s, and so the point of what I'm trying to get to is that what we are talking about is not a drug-induced psychosis.
Correct.
This is schizophrenia.
The organic, it's building in somebody's mind over the course of their entire life, but then starts to manifest once you get into that. Late teens, early 20s is when it's commonly seen. Yeah. Okay. So schizophrenia, we break down the symptomatology of schizophrenia into what we call positive symptoms. There's also negative symptoms of schizophrenia, and then what we call cognitive symptoms. So if I can run through kind of the positive symptoms, these are the ones that we all would kind of immediately think about when we think about the schizophrenic patient. So these are the people who are having delusions, the positive symptoms of a delusion. So these are false beliefs that are not rooted in reality. You also have the hallucinations, which can accompany somebody who is a schizophrenic, the disorganized thinking, so the incoherent speech, kind of the trouble organizing their thoughts, and then oftentimes it can also be manifest with some abnormal motor behavior. So just their ability to just move around in their environment can be impaired.
And super agitated too sometimes.
Super agitated, absolutely. But then contrast that with the negative symptoms of schizophrenia. So these are what we call a blunted affect. So I use this in my medical documentation a lot. Patient has a blunt affect, so they're just sitting there. They're very withdrawn. They're not responding to the environment around them, and they very limited expression, very limited emotion. Avolition is another thing. So it's kind of decreased motivation to start activities. So that kind of starts to bleed over into your depressive symptoms with the negative symptoms of schizophrenia. Anhedonia, so an inability to feel any kind of pleasure, not seeking out things that would normally make you or I feel good about ourselves during the course of our day. And then that social withdrawal, which is also kind of comes with a stigma that we talked about in our last module in the schizophrenic patient who's hearing voices and maybe seeing things, having those delusional beliefs. They might become shut in. They don't want to have people aware that they're sick, which can really put them on a glide path downward into getting really, really ill. And then the last thing is our cognitive symptoms of schizophrenia. So this is really just poor executive functioning. So you have trouble planning your day. You have difficulty making decisions. And these are the times. That's the 18-year-old kid that was a straight A student goes to college and all of a sudden they're failing, just because they can't put one foot in front of the other. They can't do the high functioning things that they need in order to live in society.
And oftentimes they don't even really know, before they're really diagnosed, you don't really know what's going on either. They're trying to process what's going on. But I get back to that affect. I mean, that blunted affect is like I'm looking at you, I'm interacting with you, I have facial expressions. These individuals aren't making eye contact.
Right.
Their face is like the lights are on and nobody's home. And some of that is the fact that they're trying to figure out how this internal stimuli that is triggering them, and they're trying to process like, what is that and what do I do with that? Which also leads to other things like individuals can't hold down a job. Right? They frequently have a very difficult time staying employed because of bizarre behaviors, bizarre responses, the affect, like never involved in a service industry because they're just blunted. Right,
and falling down the social ladder, leading to being unsheltered, then leading to substance use, and all of those things kind of mesh together into a really bad place for people.
Right.
Yeah. All right. So some of the treatments that exist for folks who have schizophrenia. So these are our antipsychotic medicines. Essentially, they can be divided into two different classes. So your first generation are what we call your typical antipsychotic medications. So these are the ones that we all have on top of mind. So your haloperidol is the kind of prototypical, typical medication which can be used to treat schizophrenia. And then we have our second generation medications, so what we call atypical medications. The atypicals really to take a step back, so as far as the pharmacology behind it, so our typical medicines like Haldol or haloperidol, they block dopamine receptors in the brain, which will have the effect of reducing the hallucinations that people have, decrease the delusional thinking, and really just quiet the mind, which will help with the schizophrenic symptoms. Your atypical medications for schizophrenia, so these also block dopamine receptors. But they also block the serotonin receptors within the brain, and kind of balancing out our neurotransmitter levels, which will have the same effect of decreasing hallucination, quieting the mind, decreasing the delusional thoughts. But one of the things that we see with our atypicals, and we see a lot of these now, people coming in on medicines like risperidol or Zyprexa or olanzapine, Seroquel is one that we see a lot. We see a lot of Geodon and Abilify. These are medicines that are better for folks in that they don't have a lot of the side effects. So the tardive dyskinesias that can come from the earlier medicines where people have uncontrolled facial movements and things, and be a reason why people don't want to be on medicines, and getting into more of a problem with sliding down into that deep dark place where they're not getting their schizophrenia treated because of some of the side effects. Yeah. So some of the atypical medicines have come forward, I think open the door for people to get more medication help that they need. But then there's also other medications that you might see our schizophrenics using. So things like antidepressants or mood stabilizers, and even some of our anti-anxiety medicines can be used as adjunct therapies alongside of our antipsychotics that we just talked about.
Yeah, so I think that when you're going through this training, you're trying to process like what is it that I need to kind of grasp onto? I mean, knowing calling it typical and atypical are okay. Don't ask us why they named them typical and atypical. I mean, because that atypical sounds like bad, right? But it's not, and we didn't name it. But the common things like the Zyprexa, olanzapine, which is Zyprexa is the trade name, olanzapine is the generic name, like risperidol, Abilify. So when you encounter a patient and you're asking what their history is, then it's helpful to know that, oh, this is an atypical antipsychotic. I learned this in my TAD training, and it gives you some predictability of the person you're dealing with, right? The patient that you're taking care of, it's like if they're on some of these antipsychotics and they clearly have a psychotic history, right? And then you try to tease apart what is that. Dopamine and serotonin are kind of cool to know, but I think that's kind of cool to know once, maybe. I don't know. I'm okay not having like, oh, that's a serotonin receptor blocker. Like, I even have trouble with that even these years later. But I think that the important take-home point here is knowing the common medications and knowing the kinds of patients that they are given to will help you as a clinician on the street go, oh, okay, this person has a history of psychosis.
And so much of what we do is pattern recognition.
Yes.
Right? So we're good at seeing that EKG, and it's a pattern recognition. Is this a STEMI in the field? But now you go and you talk to a family member, or the family member brings out the bag of medications, and they spill it out on the table, and you can start to put the pattern together. So I've got somebody that has, maybe a blunt affect, and I see that, oh, you take Geodon, or oh, you take Zyprexa, and it can start to really put the pieces together in your mind, recognizing the pattern, and then reacting according to the pattern that you see.
Exactly. All right, so I'll take on the mood and affective disorders. So these disorders are conditions that really affect a person's emotional state. And again, getting back to our spectrum, there's a spectrum of these disorders. There are some that live more in the deep depressive state. There's some that live in both the deep depressive and the manic state. And then there's the in-between as well. So major depression disorder is a persistent sadness. They're sad all the time. There's just a loss of interest in life. A lot of these folks may not eat. They may have trouble getting out of bed. They definitely are having difficulty with their close relationships. Then this could also manifest as physical symptoms like chronic fatigue and things like that, concentrating, and ultimately could unfortunately lead to death or suicide.
That's right.
And then you get this next one, which is bipolar disorder, which is that person, as the name insinuates, lives on two sides of the world. They're either in this deep depressive state or they're almost in a manic state. And when you see someone who's manic, this is someone who maybe have pressured speech. They may be talking really fast. They'll have extreme difficulty concentrating. And then they also get into like these really risky behaviors. This is a person that's going to take their like life savings down to a casino and start spending all their money.
Or they're going to go buy a car that they have no need for, or spend that ton of money.
Yeah, show up with a Ferrari at work.
That's right.
So these are and then there's also hypomanic. So some folks don't quite get into the real manic, but they get hypomanic. And then the next,
in the middle, exactly.
Yeah, where they're just kind of a little depressed from time to time, and they're not so depressed from time to time, but they don't quite meet the full criteria for bipolar. And then there's a dysthymia or persistent depressive disorder. This is the person who is sad and just has these chronic depression symptoms
for a long time.
For a really, really, really long time. Yeah, exactly. So again, this is where I would start thinking about trying to remember the names of some of these medications that are used to treat depression, because that's going to really give you the clue.
Seeing the patterns.
Seeing the patterns, exactly. So this is the Prozac, the Zoloft, Celexa, Lexapro. So you're hearing names of medications that you did not hear in the schizophrenia world. However, some of these individuals could be on both. right? And then there's also serotonin reuptake inhibitors, again, maybe for a test, but not as important, I think, to remember for TAD.
Right.
And then remember the medications we all studied about and were maybe tested on the National Registry examination, like Elavil or nortriptyline or amitriptyline, right? The tricyclic antidepressants are out there. So those are some of the common types of medications. And then there's also some mood stabilizers like lithium and lamictal, which is also doubles as an anti-seizure medication. Yep. And then you do sometimes get these antipsychotics, as I mentioned a second ago, where you could have someone who's on both.
They could have a dual diagnosis. So,
exactly. So, the schizophrenia drives them into depression, and then so you're treating both of them.
That's right. Okay, so the next one we're going to talk about is our anxiety disorders. So this is defined as a group of mental health disorders which is essentially characterized by excessive worry. I'm worried about shooting this video today, but it doesn't mean that I've got an anxiety disorder. But certainly how your excessive worry or your fears impact your day-to-day functioning. So we can break that down further by talking about things like generalized anxiety disorder. So this is a persistent kind of excessive worry that is pervasive throughout your day. So everything that you do, you worry about. And you can imagine just how debilitating that can be for people. We've got panic disorders. So these are recurrent, unexpected episodes of just sheer immense fear that can be triggered by different events, and those oftentimes will have physical symptoms. So these are people that are calling 911 because they're having palpitations or they're feeling short of breath, but it's because they were triggered by having a panic event. So, and sometimes that could be as simple as a fear of walking out your front door and being out in the community to leading to being that triggering event. We have social anxiety disorders, much like I just talked about. So intense fear of social interactions or social situations, fear of being judged or scrutinized, fear of presentations can also be part of our anxiety disorder, anxiety disorder spectrum. And then specific phobias. So the folks who are scared of snakes, scared of spiders, scared of enclosed spaces. Agoraphobia, I mentioned it earlier, that person that has a hard time walking out the front door because they have a fear of open spaces and a fear of coming into contact with the community. And then also separation anxieties. So this can also be a reason for folks to be engaging with 911. So if excessive fear or anxiety about being separated from a loved one, and that could even manifest as somebody who's just, if they've just lost a loved one, that separation can be a trigger for folks. So how are those that group of clinical presentations managed, or anxiety disorder? So again, our antidepressants, the ones that you talked about just in our last segment, Kevin. So our Prozacs, our Zoloft, Celexa, Lexapro, Paxil, Effexor, Cymbalta. Those are medicines that, again, pattern recognition. If you see somebody that's calling because they're having the palpitations and they've had the panic event, and you see those medications, you can kind of put that together as far as what their history could be.
Yeah, and a lot of these conditions, and the reason why you hear us talk about receptor blockers or reuptake inhibitors, gets back to the structural side in the brain of how some of these conditions manifest themselves. So, for example, like you just mentioned, Prozac and Zoloft and Celexa, they're selective serotonin reuptake inhibitors. So, first of all, their safety profile is pretty big. Right. They're safe drugs to take, even in someone who takes them in overdose. They're not generally going to be as deadly as if they overdosed on amitriptyline, as we know, tricyclics. But in the name, it says what it is: selective serotonin reuptake inhibitor, right? So these individuals have imbalances of serotonin. When they found what they don't have the reuptake of serotonin, they have more serotonin available for their receptors, and the symptoms are mitigated.
Right. Yeah. Right. And they're feeling better. You're less in that deep depression. You're elevated. Yeah. The other medications that folks can be using with anxiety disorders, we come across this, are benzodiazepines. So these are medications like Xanax is very common in the community. Ativan is another common one that people have when they're feeling that panic or that anxiety symptom. Another one that we commonly see is beta blockers. So there's one that's called propranolol that's often out there that we see on people's medication lists. And it's just meant to essentially just calm folks down so that they can just go about their life and just have a little bit of a less kind of hyperactive state. And then another one that we see a lot is buspirone or Wellbutrin. That is a common one that our primary care doctors and psychiatry staff really across the county are using to manage anxiety disorders.
Yeah, I think those would be the common ones. You'll see the SSRIs out there, selective serotonin, like the Paxils, the Prozacs, and then you'll also see the Wellbutrin a lot.
That's right. That's right.
All right, so the last big class is personality disorders, and so this is a group of conditions that are characterized by behavioral and cognition and experiences that deviate from some cultural norms. So the big one that comes up here and that we see a lot of in the emergency department is something called borderline personality disorder. You may not have ever heard it, but I can probably guarantee you've seen it. You may not have recognized what you're seeing at the time, but these individuals are characterized by super unstable moods, and they have relationship problems and behavioral problems. And I think the word that comes up probably most is splitting. And so you're either their best friend or their worst enemy, and you can be the same person, right? You can go from like they're getting something that they feel like they need from you, and you become their best friend. And then when you take that away, they don't like you anymore. So there's these irrational instability and they have these feelings of worthlessness, and they're very impulsive as well.
So they're calling 911 because they want help, but then you, the helper, arrives and they don't want anything to do with you, or they're openly hostile or angry towards you. That should be, again, pattern recognition that this is somebody that might be suffering from borderline personality disorder.
Or they'll anchor on your partner. Right, they'll say, I don't want to talk to you, but I'll talk to you. Where they're just that splitting. Think of splitting, where they're just trying to segregate things, and I feel like it's just sometimes how they can control the emotions that are going on inside. Another one, antisocial personality disorder. This is disregard for the rights of other. You can see this in kids as well, but it's not quite called that. At that point, they may be manipulative or deceitful or trying to hide things from you, and they oftentimes these individuals will exhibit some sort of criminal behavior as well. Right. Narcissistic personality disorder. This is a tough one. You may not know you're looking at that when you actually are, and this is an individual that has an overinflated view of their position, their status, who they are, and this grandiose kind of need for admiration.
That's right.
And for reaffirmation of who they are. Obsessive compulsive disorder. I think everyone watching this has probably heard about this or kind of know what that is, but that's the counters, the checkers, the person that has to have a very structured routine and a preoccupation with that routine. And when it gets disrupted, it creates a lot of trouble for them. Orderliness, perfectionism as well. And then the avoidant personality is that person that's extremely shy. They don't feel adequate. It's almost the opposite of a narcissist, but not quite the full opposite. And they're really sensitive to rejection. So this group of individuals and the personality disorders also comes with some common medications. You'll see these names come up again. Right? So these are the SSRIs again, the selective serotonin reuptake inhibitors like Prozac, like Zoloft, like Celexa. And then some mood stabilizers as well, which we also saw kind of in the anxiety world as well, like lithium, and you can see Depakote as well. And Depakote seizure medicines, right? And so in certain levels and quantities, these medications will either help with seizures or they can help with mood stabilization. So when you see Depakote in someone that does not have a history of seizure disorder, or Tegretol, also called carbamazepine, you're like, well, that's a seizure medication, but this person doesn't have a history of seizures. They're being used as a mood stabilizer. So this person probably has some sort of personality personality disorder. And then you'll also see the antipsychotics creep in here. And so I think the one take-home lesson out of all four of these is the fact that this is not, oh, you fall into one of these.
Right.
Okay, these blend.
Absolutely. You will often see concurrent mental illness, schizophrenics with personality disorders, with anxiety disorders, all kind of blending together. And that's why sometimes people's medication lists can become pretty complex, and being able to kind of look and tease them out can give you a lot of information about a patient, even without you even getting any opportunity to speak to somebody. You can figure stuff out from people.
Yeah, and the good news, I think, out of this program, out of the TAD program, is that we're not expecting you to be psychiatrists, psychologists, right? That is not the role here. The education here is meant to give you awareness of what is out there, because some of these individuals, well, all of them, you'll need to make a dichotomous decision. Is this person too sick to go to one of our facilities, or are they well enough but still sick enough that they could go to an alternate destination? And
do they fit into one of these buckets of mental illness?
Yeah.
Right. So is this even the top line? Is this person suffering from a mental crisis, or is it a medical concern?
Yeah.
So there's some other non-pharmacologic therapies that you can encounter for folks who have mental illness. So these are things like cognitive behavioral therapy, talk therapy, being able to have a discussion with a mental health professional to kind of reframe the thinking around some negative self-talk and other things that can lead people into mental crisis. There's other types of behavioral therapy. There's dialectical behavioral therapy, which focuses on teaching skills to manage emotions, kind of how people can off-ramp and kind of reduce some of their own self-destructive behaviors. Interpersonal therapies, so aims to improve relationships, so bringing in family members into therapy sessions. And then psychodynamic therapy, so essentially understanding and resolving prior events, which could be causing people to have a manifestation of mental illness. Also behavioral interventions that exist, so behavioral activation, so encourages engagement with meaningful activities that will combat depression. Exposure therapies, so if you have a specific social phobia, so getting you in a controlled way into that environment that you don't want to be in, can kind of lessen the burden when you get into that situation.
I wonder if Indiana Jones went through that
with his snakes.
Right, so you just gradually expose him to like a fake snake.
Right. I hate snakes.
I hate snakes. Right. Exactly.
And then mindfulness-based stress reduction, so combining meditation and other things like yoga in order to get people through some of the stressors that can manifest as mental health disorders. And then we like to include these types of interventions because you're going to encounter folks on the street that they will have a 911 complaint. You'll go talk to them and they're going to say, nope, I don't want to go. I don't want to go to the hospital today. You want to meet them in the moment and be able to speak to them kind of where they are. And I think that's an important concept for us because I think it's going to encourage your patients and the people that you're seeing to engage with you. And you meet them in the moment. Okay, you don't want to go to the hospital today. You've got capacity for choice. I can't compel you to go. But I can maybe talk to you about some of these things. I can maybe mention, hey, when you talk to your primary care doctor, maybe there are some other things. If you don't want to take a medication, there are certainly some other things that could be done to kind of get you the help that you need. So important to kind of keep that in mind. And I guess we're going to end here, and we're going to go on with a case where we talk about mental health, mental disorders, and whether or not those folks are good for triage to alternate destination.
All right.
All right, welcome back. So this is a case study that's going to follow along on Module 3, which is our mental health conditions. Mm-hmm. So we'll get right into the case here. So this is a true-to-life case that came out of Sac City Fire. So we had a 59-year-old African-American woman that called 911 just stating that she was having a mental breakdown. and that she admitted to having a history of mental illness on the call, but then was saying that she's just really not in a good place. So initially that call was routed over to the suicide prevention hotline 988, where they were able to get some further information. So they were able to figure out that she had a known mental health history. They weren't able to assess whether that she had access to weapons, which is a common thing for folks who are maybe suicidal. We want to know, do they have weapons access? They were able to ascertain that she was responding normally to questioning. That she didn't have any suicidal thoughts or plans for self-harm, and that she hadn't injured herself in any way. So from there, our paramedics were dispatched to the scene, and they went to, I'm assuming this was kind of like a hotel kind of place where they were able to meet her in a hallway. So they found that she was walking, she was ambulatory, she was alert, she was oriented, knew where she was, knew date and time and her name. She had a GCS of 15. Her blood pressure was 168 over 102. Her heart rate was 102, and she had a respiratory rate of 18, and then she had a normal oxygen saturation. They did a finger stick glucose, which is fantastic, which found the glucose level was 133. She had clear speech. She was moving all of her limbs. There was no concern for stroke or anything along those lines. And that she verbalized to the crew that she was having spiders crawling all over her, and that she was actually having them in her ear as well. But the crew was looking at her and be like, I don't see any spiders or infestation here. And she was extremely anxious.
So let's just take a pause here and talk through some of the key. So if I'm now in a situation where I've been authorized to transport to an alternate destination, some of the things I'm seeing here so far that are good are the vital signs are okay. Now I understand there's some hypertension there, right? But hypertension that is asymptomatic is not necessarily something that needs to go to an emergency department. She's a little tachycardic, but she's also anxious, right? And she's got normal oxygen saturations. The blood glucose, the 133, that is key, because these facilities, right? Some of these facilities, they're not medical facilities, that are going to be able to handle someone who is hyperglycemic with a blood sugar of like 450 or has symptoms of DKA, right? So we need to know that before we're going to transport them there. But talk to me about what your initial thoughts are. These spiders crawling. What do you think? What do you think that is?
Sure. So she's complaining about these things, and you're looking at her. You're looking at the skin. You're doing the deep dive, your good physical exam, and you don't see the things that she's pointing to. And this is a common. No, I wouldn't say super common, but we do see it a lot in our emergency departments. So delusional thoughts that you have. Infestation or some type of insects or whatever on your skin or on your body. And oftentimes this comes hand in hand with schizophrenia and the substance use disorders that are often hand in hand with schizophrenia, and particularly methamphetamine use.
Yeah. So this is psychosis. Right. Of the things we just talked about, this is a good example of psychosis. And she also has these elements of anxiety.
Correct. So we kind of, how this case resolved is, so the patient was initially brought to one of our local emergency departments. Obviously, before we had triage to alternate destination authorized in our region. She was seen by an emergency physician, and she eloped several hours later. So was sitting in likely one of our hallway beds or a treatment space where we were just trying to make sure that she was safe and that didn't have any medical concerns like DKA or things like that. And she eloped prior to being seen by one of our psychiatry staff. So this is delusional parasitosis. So again, a fictitious belief that you are infested with parasites or other insects. One of the things, the hallmarks of this is oftentimes people will bring in a little baggie that has little bits of thread or hair or things, and they're convinced that these are the things that are crawling in their skin, but it's clearly not an actual insect or bug. We talked about the fact that this is commonly seen with schizophrenia and methamphetamine use. So Let's then look at this case, kind of take back the 30,000-foot view here and look through the lens of triage to alternate destination. So would this be person be a candidate to be taken to an alternate site? So clearly, I don't think, Kevin, do you think this is somebody who's intoxicated?
No, I don't think so.
I don't think so. So I don't think that it wouldn't be good to bring this person to a sobering center.
Yeah, so the hallmark signs of that are they slurring their speech? Are they stumbling?
Right.
Those are all signs of intoxication, and so she didn't appear intoxicated.
She did not, no. But then you need to think, okay, is this person that could go to a behavioral health crisis center or a mental health treatment facility? And so the first question you have to ask yourself as a provider is, do you have a primary impression of a behavioral crisis in this patient?
I did.
I think so. Especially because your exam doesn't show you the thing that she's fixated on and complaining about. You kind of crossed the initial litmus test, as it were, for triage to alternate destination, because your primary impression is that there's a behavioral crisis here. You've got somebody who is voluntarily or on a 5150 hold. So I think in this case, the law enforcement was actually dispatched with the initial call and was on scene and had put this person on a 5150 hold, because they were kind of the same mind, thinking that we don't really know what this is, and oftentimes as reflexive holds are placed. Mm-hmm. So patient was on a 5150. They're ambulatory, so they don't need a wheelchair. They don't have walkers or other kind of barriers that might keep them out of a triage to alternate destination site. Do you think they had an emergent medical condition? Didn't seem like it.
I didn't think so. I mean, we talked about the high blood pressure, we talked about the mild tachycardia, mm-hmm. And she wasn't hyperglycemic or high. I don't think so.
Yeah. And she had a GCS of 15. She wasn't giving you other indicators that she was ill. She had more or less stable vital signs. And again, these fit within our established norms for what vital signs would be in order for a patient to go to a triage to alternate destination site. And you'll also see that those vital signs fit within something that you're also very familiar with, and that is our 50-50 policy.
Yes.
So we've taken aims in Sacramento to make sure that there's one set of vital signs that is deemed to be stable. Mm-hmm. So that way you don't have to have, okay, what are my waiting room criteria vital signs? What are my TAD vital signs? What are my other program vital signs? We want to make sure that it's all one lane, so you get these numbers in your mind, and then you can apply them to all these different situations.
Right.
Okay. GCS was greater than or equal to 14. We put it at 14 because for sobering centers, mm-hmm. people can have a GCS that's a little bit decreased when they're mm-hmm. intoxicated. And our blood sugar fell within greater than 60 and less than 350. Mm-hmm. That's what we've established as being our kind of the put the fence around that, the blood sugar number. So with all of that said, yes, I think this patient would have done well going to in this case either or one of our alternate destination sites for mental health treatment.
Agreed.
Okay.
All right, so that wraps up Module 3.
That's done.
Wow. All right. So stick around. There's more coming. Remember, you don't have to complete all of these in one sitting or even in one day. We want you to really take the time to absorb what you're teaching. We're trying to throw pearls in there as well. Mm-hmm. Personal experiences and also just some guideposts. But in this particular case, before we leave this, I want to get back to something you said, and that is ambulatory. A person's ambulatory state. That is important to the facilities.
Right.
A lot of these decisions, well, actually all of these decisions were made in, and correct me if I'm wrong, made in agreement with the providers that are at these facilities, mm-hmm. or at least their directors, and so that we're not showing up with somebody who can't walk.
Right.
Because they're not equipped to be able to handle that.
Right, because those people bring a lot of other medical needs with them. Oftentimes, the inability for those facilities to disposition them, to get them home or to get them to other places. So we want to be bringing the right patient to these facilities so that they can get the care that they need and then make space for the next patient.
Yeah, absolutely. All right.
We'll see you for Module 4.